Good afternoon, students. The topic of our lecture is features of clinical examination of orthodontic patients, additional methods of research in orthodontics, such as functional, anthropometric, biometric, radiological. The most important part of orthodontic treatment is the patient's assessment. Once a particular treatment strategy is started, subsequent changes are often difficult. Inappropriate orthodontic treatment can produce adverse results, and it is essential that full examination of the skeletal form, soft tissue relationships, and occlusal features are performed prior to undertaking treatment. It is sensible to carry out the assessment in a logical order so that none of the steps are missed. A simple assessment should include the following: medical history, patient's complaint, extraoral examination, intraoral examination, additional methods of examination such as anthropometric methods, X-ray examination, methods of research of speech, respiratory, masticatory, swallowing function, justification for treatment, treatment aims, treatment plan. The clinical dental examination is an essential part of dentistry and guides every treatment plan. A thorough orthodontic study begins with a systematic external examination, which includes a general assessment of patient's awareness, posture, temporomandibular joint, head, neck, skeletal pattern, and soft tissues. It is important to observe the patient at rest and in function without their awareness. This approach increases the accuracy of the assessment. The extraoral examination commences in the waiting room or consultation room. The orthodontist assesses height, level of physical development, physique, posture, compliance, level of comprehension and communication. The key to the extraoral assessment is an understanding of the normal proportions of the face and recognizing when patients deviate from these normal relationships. An appropriate goal for the facial examination, therefore, is to detect disproportions. The patient needs to be examined in a frontal view, assessing in the vertical or transverse planes, and in profile, assessing in the anteroposterior or sagittal and transverse planes. The first step in analyzing facial proportions is to examine the face in frontal view. In the frontal view, one looks for bilateral symmetry and for proportionality of the width of eyes, nose, mouth. A small degree of bilateral facial asymmetry exists in essentially all normal individuals. This normal asymmetry, which usually results from a small size difference between the two sides, should be distinguished from a severe disproportion and aesthetic problems. The soft tissue lesion, middle part of the upper lip at the vermilion border, and the chin point should all be aligned. In this photo, the patient has a symmetrical face with the facial midline showing alignment of the soft tissue lesion, middle part of the upper lip at the vermilion border, and the chin point. Here we may see a patient with a marked mandibular asymmetry to the right. The face can also be divided into fifths, which each section being approximately equal to the width of an eye. The face can be assessed vertically in two ways, using the rule of thirds, measuring the angle of the lower body of the mandible to the maxilla. First, the face can be divided into equal thirds, hairline to glabella between eyebrows, forehead, glabella to subnasale, middle third, and subnasale to lowest part of the chin, lower third. In a face with normal proportions, each third is approximately equal in size. The lower third can be divided into the thirds with the upper lip line in the upper third and the lower lip line at the top of the lower two thirds. An increased lower facial height is commonly seen in patients with a class 3 skeletal base, owing to the prominence of the chin. A decreased lower facial height is seen in patients with class 2 skeletal base with a retractive mandible. If the lower facial height is reduced, this can result in a deep overbite. Conversely, if the lower facial height is greater than 30%, this can produce an anterior open bite. Another clinical method is to assess the angle between the lower body of the mandible and the Frankfurt horizontal plane. The Frankfurt plane can be estimated clinically by palpation of the lower body of the orbit. The angle is considered normal if the two lines intersect at the occiput. The shape and size of the face are determined by the ratio of vertical and horizontal parameters. Garson proposed to calculate the morphological index of the face. This is the percentage of the morphological height of the face to the largest zygomatic width. They offer single out 5 types of faces. First, very broad face. The index value is less than 78.9%. Wide face from 79 to 83.9%. The average face 84 to 87.9%. Narrow face from 88 to 92.9%, and very narrow face 93% or more. The anterior-posterior relationship of the jaws can also be assessed using the convexity of the face. This is assessed by the angle between the upper face from glabella to subnasale and the lower face from subnasale to pogonium. The mean value is from 165 to 175 degrees. This is the assessment of the relative position of the maxilla and the mandible. It is classified as Class 1 skeletal pattern. The mandible is about 2 to 3 mm posterior to the maxilla. The patient presents with a straight profile, known as a mesognatic profile. The harmony between the maxilla and the mandible creates this straight profile. Class 2 skeletal pattern. The mandible is too far posterior in relation to the maxilla. the patient presents with a convex profile known as a retrognathic profile. Class 3 skeletal pattern. The mandible is positioned anterior to the maxilla. The patient presents with a concave profile known as a prognathic profile due to overgrowth of the mandible. Most patients seek orthodontic treatment to improve their smile. So, smile aesthetic is also an important component of orthodontic treatment planning and should be formally assessed. A normal smile should show the following. Ideally, 75 to 100% of the maxillary incisors should be shown when smiling, but this also reduces with age. The full height of the maxillary incisor crowns should be visible on smiling. Some gingival show is acceptable, but this should not be excessive. A gummy smile is the term given to a higher than average lip line which exposes excessive gingiva. The gingival margin of the maxillary central incisors and canines are level, with the lateral incisor margin situated slightly below this. The lips should correctly frame the maxillary dentition with bilateral buccal corridors, visible but not excessive. The buccal corridor is a space formed between the inner buccal surfaces and the maxillary molars upon smiling. An aesthetically pleasant smile has reduced buccal corridors. Relationship of the upper incisor edges with the lower lip. The upper incisor edges should be parallel to the curvature of the lower lip on smiling. This is known as the smile arc. Flattening of the smile arc will result in a less attractive smile, which can also be associated with premature aging. In addition to assessing the smile aesthetic, a lips will also assess. Lips can be competent, that is, meet together at rest. Then, potentially competent position of incisors prevents comfortable lip seal to be obtained at rest, but the patient can hold the lips together if required. Lips can be incompetent, require considerable muscular activity to obtain a lip seal. The nasolabial angles is formed between the upper lip and base of the nose columella and should be between 90 degrees and 110 degrees. It gives an indication of upper lip drape in relation to the upper incisor position. A high or obtuse nasolabial angle implies a retrusive upper lip, whilst a low or acute angle is associated with a lip protrusion. The use of Ricketts aesthetic line provides a guide to appropriate prominence of the lips within the face. Ricketts ear plane is a line joining soft tissue chin and tip of the nose. In a balanced face, the lower lip should lie 2 mm anterior to this line, with the upper lip positioned a little further posteriorly to the line. Horshilkina used the Ricketts method. Depending on the location of the lips according to aesthetic plane, it can be identified four types of face profile. First type. The lips are located in front of the aesthetic plane. At an equal distance, on lip prevails upper or low. Second type. The lips touch the aesthetic plane. Third type. The lips are located behind the aesthetic plane. At an equal distance, on lip prevails upper or low. And fourth type, different combinations of the above options. The intraoral examination commences with an assessment of the soft and hard tissue for any lesions, congenital abnormalities, and evaluation of the occlusal relationships. Using a good source of light, dental mirror and probe examine the oral mucosa and vestibules, the glands, the frenum, the health status of the gingiva, the gingival margins, the soft and hard palate, the tone. Teeth must be charted carefully and all findings must be recorded thoroughly. It is recommended to begin the examination from one quadrant and move across to the next, assessing and recording the presence of pathology, detected caries, erupted teeth, enamel morphology, missing teeth, and reason for tooth loss, previous dental treatment, previous or current trauma. It is extremely important to know the pattern of eruption to assess the dental age. Delayed eruptions, particularly asymmetrical delayed eruptions, may indicate an underlying problem such as a supernumerary teeth, ectopic eruption, or impaction. The arches are now assessed in occlusion. The incisor relationships are assessed first. The incisor relationship is described using the British Standards classification, but also needs to be supplemented with a description of the overjet and overbite. British Standard classification on incisor relationships is most widely used descriptive classification. Class first, near occlusion. The low incisor edges occlude with or lie immediately below the cingulum of the upper central incisors. Class 2, distocclusion. The low incisor edges lie posterior to the cingulum of the upper incisors. There are two subdivisions to this classification. The first division is protrusion of the incisors resulting in an overjet and the second division results in a deep bite as the upper central incisors are retroclined. Class 3, mesoocclusion. The low incisors lie anterior to the upper central incisors. There is reduced or reverse overjet. The overjet should be measured from the labial surface of the most prominent maxillary incisor to the labial surface of the mandibular incisors. The normal range is 2 to 4 mm. If there is reverse overjet, as can occur in a class 3 incisor relationship, this is also measured and given a negative value. In this photo we can see class 1 occlusion. Next, reduced overjet associated with the class 2 division 2 incisor relationship. The buccal segment relationship is half a unit class 2. Then, increased overjet associated with a class 2 division 1 incisors relationship. The buccal segment relationship is a full unit class 2. And next, reverse overjet associated with the class 3 incisor relationship. The normal range is for the maxillary incisors to overlap the mandibular by 2 to 4 mm vertically, or 1/3 to 1/2 of their crown height. Overbite is described as increased if the maxillary incisors overlap the mandibular incisors crown vertically by greater than 1/2 of the lower incisors crown height. Described if the maxillary incisors overlap the mandibular incisors by less than 1/3 of the lower incisors crown height. If there is no vertical overlap between the anterior teeth, this is described as an anterior open bite, and a measurement should be made of the incisor separation. If the overbite is complete to the gingival tissues, it is described as a traumatic if there is evidence of damage. Teeth in anterior crossbite should also be noted along with the presence and size of any displacement of the mandibular that may occur when closing in the retruded contact position into the intercuspal position. Maxillary and mandibular dental center lines are assessed in relation to the facial midline and to each other. The center lines should ideally coincident with each other and to facial midline. Displacement of a center line can be due to asymmetric dental crowding, buccal crossbite with a mandibular displacement on closing, and skeletal asymmetry of the jaws. Then the buccal relationships are assessed, canine and molar relationships, any lateral open bites and crossbite. The buccal segment relationship is described using the angle classification. Molar relationship, class 1, nitroocclusion. The major buccal cusp of the upper first molar occludes on the major buccal grooves of the lower first molar. Class 2, distocclusion. The lower first molar is positioned distal to the upper first molar. Class 3, major occlusion. The lower first molar is positioned medial to the upper first molar. Canine relationship. Upper canine occludes on the medial half of the lower first premolar and the distal half of the lower canine. Upper canine occludes anteriorly to the lower first premolar. Thus, the distal surface of the lower canine lies posteriorly to the medial surface of the upper canine by width of a premolar. If it less than width of a premolar, it is given the term tendency towards class 2. The distal surface of the lower canine lies anteriorly to the medial surface of the upper canine by width of a premolar. It is less than width of a premolar, it is given the term tendency towards class 3. A crossbite is discrepancy in the buccolingual relationship of the upper and lower teeth. The transverse relationship of the dental arches is described in occlusion. Crossbites are described in relation to the arch, whether they are localized or affect the whole segment of the dentition, and if they occur uni or bilaterally. When examining the functions of maxillofacial area, orthodontists should be evaluated the type of breathing, the function of swallowing and speech, function of temporomandibular joint. It is important to note the presence of any signs of an orofacial myofunctional disorders. An orofacial myofunctional disorder is when there is an abnormal lip, jaw, or tongue position during rest, swallowing, or speech. Test for revealing pathologic mouth breathing. To discern improper mouth breathing, the orthodontist can use the Rosenthal test. While the child is taking 10 to 15 deep breaths with his or her mouth closed, inhaling and exhaling through the nose, the practitioner measures the patient's pulse rate. Children who are normal nasal breathers have no difficulty in complying and show no rise in pulse rate. Gradient mirror test. A cold mirror is placed under the child's nostrils, and he or she is asked to inhale and exhale through the nose. If moisture condenses on the mirror, this demonstrates that the patient has successfully exhaled through the nares. After the second output of air on the mirror, mark the halo area with a marker. Low nasal flow up to 15 millimeters. Average nasal flow 50 to 60 millimeters. High nasal flow above 60 millimeters. Then, water retention test. Place water in the patient's mouth, approximately 15 milliliters, and ask him or her to hold it for 3 minutes. Nares reflex. The Nares reflex test shows whether or not the nose is functioning normally. While the child's mouth is closed, the orthodontist pinches the patient's nostrils for 2 seconds and then releases them. The area of the nose should flutter and pad. Mouth breathing contributes to protrusion of upper incisor teeth, distal displacement of lower jaw, narrowing of upper jaw, formation of anterior open bite. In this case, the external examination allows revealing the abnormality of lip seal and tongue position, a broad nasal bridge, narrow nose, double chin. The reasons for mouth breathing can be a decreased tone of the orbicularis oris muscle, sagittal overjet interfering with the lip seal, nose, and nasopharynx diseases, as well as the habit which preserved after elimination the mouth breathing cause. In order to identify the causes of mouth breathing, the otolaryngologist consultation may be required. Inborn impairments of masticatory function, lazy and unilateral mastication may be distinguished. Unilateral chewing can lead to formation of cross and mesial bite. Lazy mastication contributes to retardation in growth of the jaws. The above impairments can be revealed during interview with parents as well as using other laboratory research methods. The orthodontist must evaluate the behavior of the lips, tongue, as they function in swallowing. Contraction of the perioral musculature indicates atypical or infantile swallowing. In this case, the tip of the tongue repulsion against the inner surface of the lips, tension of the mental muscles, and tibial symptoms are available. Temporomandibular joint examination. It is to note the presence of any signs of pathology in the temporomandibular joint and muscles of mastication during the orthodontic assessment. Any tendons, clicks, cryptus, and locking should be noted, as well as recording the range of movement and maximum opening. More than 30% of children show signs and symptoms of craniomandibular dysfunction. Orthodontists should routinely examine the functioning of patients' muscles and the temporomandibular joint, which should be palpated at rest and in movement. In the absence of malfunction, mouth opening should be rectilinear, painless, without slippage, and should extend 40 to 50 millimeters. If differential diagnosis is necessary, perform clinical functional tests. Elina-Marquessan test allows evaluation the position of lower jaw at rest and when moving in order to establish the cause of functional jaw displacement while functioning. The test consists of following 5 tests. First, determination of position of lower jaw during relative physiological rest. Evaluate the symmetry of patient's face, the height of their lower part, record posterior, anterior, and lateral displacement of lower jaw. Second, occlusion of dental arches in usual position of lower jaw. Evaluate the relationship of dental arches pain and tension to matching of the midline of upper and lower jaw, which is sometimes absent in abnormalities in transversal plane. Next test. Lowering of lower jaw and its subsequent lifting with occlusion of dental arches. Evaluate the displacement of lower jaw while wide mouth opening. If asymmetry increases while opening the mouth, it may be assumed that displacement of lower jaw is caused by pathology of temporomandibular joint. If increases in occlusion by disturbance of dental arches. Fourth test. Advancement of lower jaw forward. Evaluate any premature contacts, the size of the interocclusion space on the right and on the left, which may evidence of dentoalveolar disorders, abnormalities of teeth position. The test for differential diagnosis of mesial bite type. If patient can put the incisor teeth in the edge-to-edge occlusion, suspect the dentoalveolar type of pathology. It can be treated functionally by appliances. If cannot, gnathic type of pathology requires a combined method of treatment. Fifth test. Displacement of lower jaw to the right and to the left. evaluate any premature contacts which can limit movement of lower jaw. In normal condition, there is a canine guidance contact on the canine tooth on the working side when the lower jaw is displaced. Ashler-Bittner test allows suggesting the cause of distal bite, morphological abnormalities of lower upper jaw. During test evaluate facial profile aesthetics during slow advancement of the lower jaw by the patient to neutral relation of jaws. It is suggested that the distal bite is caused by pathology of the lower jaw in case of aesthetics improvement. The top photo shows such a case. The patient has a distal occlusion associated with mandibular retrognathia. It is suggested that the distal bite is caused by pathology of upper jaw in case of deterioration of aesthetics. The photo below shows such a case. The patient has a distal occlusion associated with mandibular prognathia. If aesthetics improves and then deteriorates, it is concluded that there is a pathology of both jaws. Dental photographs are valuable diagnostic tools in orthodontics. Dental photographs are essential medical legal documents. Photographs within the oral cavity are termed intraoral photographs, and photographs of the head and neck are extraoral photographs. The usual views taken are as follows. For extraoral, full facial frontal at rest, full facial frontal smiling, facial three-quarters view, facial profile, and intraoral frontal occlusion, buccal occlusion left and right, occlusal views over upper and lower arch. Clinical examination of an orthodontic patient is the leading method at a diagnosis admission, particularly with symptomatically diagnosis. But it is not always sufficient for a differential diagnosis admission and definition of precise clinical form of the existing abnormality or deformation. To this end, great number of diagnostic techniques, including anthropometric analysis of the study models, have been developed. The models are examined in three mutually perpendicular planes: sagittal, frontal, transversal, and corresponding directions. The width, height, and thickness of the tooth crown are measured. The width is measured in the widest part of the tooth, in all teeth at the level of the contour height, in the low incisors at the level of the incisal edge. Then, dentition's measurements. There is a certain numerical relationship between the size of the teeth and the size and shape of the dentition. In physiological occlusion, the numerical ratio of the size of the permanent incisors of the upper and lower jaws is called the tone index, which is normally 1.33. Dolgopolova studied the ratio of the sums of the crown's width of the deciduous upper and lower incisors in physiological occlusion using the tone method and confirmed their correlation. The Dolgopolova index is 1.3. Next method is Bolton anthropometric measurement. The mesodistal dimensions of the 12 lower jaw teeth from the first molar on one side to the first molar on the opposite side are summed up and divided by the sum of the mesodistal dimensions of the 12 upper jaw teeth. The resultant ratio, expressed as a percentage, is called overall. The normal value is 91.3%. In the same way, the ratio of the mesodistal dimensions of the front teeth from the canine on one side to the canine on the opposite side is determined. In doing so, an anterior ratio is obtained. The normal value is 77.2%. The proposed technique allows the doctor to determine in which area the teeth should be extracted when treating an occlusion anomaly accompanied by crowding in the anterior region. If the overall ratio in mesial occlusion is less than normal or equal to normal, and the anterior ratio is greater than 77.2%, the low dentition in the anterior section should be reduced. Conversely, if in distal occlusion the overall ratio is less than normal and the anterior ratio is greater than or equal to normal, then the upper dentition should be reduced in the lateral sections. The University of Michigan College of Dentistry has developed a method for predicting the size of permanent teeth depending on the width of the lower permanent teeth. For example, if the sum of the dimensions of the lower permanent incisors is 22.5 millimeters, the sum of the dimensions of the canine first and second premolar for the upper jaw will be 22.3 millimeters and 21.9 millimeters for the lower jaw. In adult patients, the transversal dimensions of the teeth are determined in the area of the canines, first premolars and molars. In children during the period of deciduous teeth, Dolgopolova suggested measuring the width of dentitions on the upper and lower jaws between the central and lateral incisors, canines, first and second deciduous molars. Measuring points of central and lateral incisors and canines are located on the tops of dental cusps, of first and second deciduous molars on the chewing surfaces in the anterior orifice at the intersection of the longitudinal and transverse sulcus. In the period of occlusion of permanent teeth, to determine the transversal dimensions of the dentitions, Pond's methods is used, which is based on the relationship between the sum of the mesodistal dimensions of the four upper incisors and the distance between the first premolars and first molars on the upper and lower jaws. For this purpose, Pond suggested measurement points that align when the teeth of the upper and lower jaws close, and therefore the width of the dentition is the same. In the area of the first premolars, the width of the dentition, according to Pond, is measured as follows. On the upper jaw, between the points in the middle of the tooth fissure. On the lower jaw, between the distal contact points of the buccal cusps. In the area of the first permanent molars, the width of the dentition is measured. On the upper jaw, between the points in the anterior recesses of the axial fissure. On the lower jaw, between the posterior buccal cusps. During the period of second dentition, instead of measuring points on premolars, the distal fossa of the first deciduous molars on the upper jaw or their posterior buccal cusps on the lower jaw are used. Bone-defined premolar and molar indexes, which can be used to determine the width of the normal dentition of premolars and molars as a function of the sum of the mesodistal dimensions of the four upper incisors. The premolar index is 80 and the molar index is 64. Linder and Hart tested Pond's method and corrected the index numbers. According to these authors, the premolar index is 85 and the molar index is 65. These indices can be used during and after dentition changes. The next method is sagittal dimensions of the dentitions. The sagittal dimensions of the dentitions of children during the occlusion of deciduous teeth are measured according to the method of Dolgopolova. In this case, the length of the anterior segment and the total sagittal length of the dentition are determined. The length of the anterior segment of the dentition is measured from the midpoint of the distance between the mesial corners of the central incisors, from their vestibular surface along the sagittal plane to the point of intersection with the line connecting the distal surfaces of the crowns of the canines. The total sagittal length of the dentition is measured to the point of intersection with the line connecting the distal surfaces of the second deciduous molars. The other change data of the sagittal dimensions of dentition in children with deciduous teeth in physiological occlusion are present in this table. During occlusion of permanent teeth in the sagittal direction, the length of the anterior segment of the upper and lower dentition is measured according to the Kohlhaas method. Kohlhaas enriched Pond's method by proposing to determine the length of the anterior segment of the dentition according to the sum of the measured distal dimensions of the four upper incisors. Measurements are taken from the contact point on the labial surface of the incisal edges of the central incisors to the point of intersection with the line drawn through Pond's points in the area of the first premolars. Kohlhaas compiled a table of anterior upper dentition length values for various sums of the width of the four upper incisors. The figures reduced by 2 mm corresponding to the thickness of the upper incisors can be used to determine the length of the anterior segment to the lower dentition. Then, Gerlach method. Gerlach offered to study the proportionality of the dental arch of the upper and lower jaws by the correlation of segments which were singled out by him: anterior, which includes 4 incisors, and 2 lateral, right and left, which include a canine tooth, premolars, and first permanent molars. The anterior upper segment and the anterior lower segment are detected by the sum of the measured distal dimensions of the upper and lower incisors. The lateral segments of both upper and lower jaws on the right and on the left are measured by the size of a chord. Chord is the line which joins the mesial surface of canine teeth in the point of contact with the lateral incisors and the distal surface of first molars in the point of their contact with the second molars. Gerlach's formula for studying dental arch segments correlation is presented in the slide. The apical base is a conventional line that runs at the level of the apices of the roots of the teeth on the upper and lower jaws. The dimensions of the apical base are studied in the transversal width and sagittal length directions according to the House method modified by Snagina. The width of the apical base on the maxilla is determined on the plaster model by a straight line between the deepest points in the fossa canina, that is, in the recess between the apices of the canines and first premolars. On the mandibular model, the measurement is made between the same teeth receding from the level of the gingival margin by 8 mm. The length of the apical bases on the plaster model of the upper jaw measured along a perpendicular from the point of intersection of the median palatine suture line connecting the central incisors in the neck palatal surface to a line linking the distal interproximal crown surfaces of the first permanent molars. On the basis of the mandibular apical length measured from the contact point of the medial angles of crown's mandibular central incisors to a transverse line connecting the distal interproximal crown surfaces of the first permanent molars. Normally, the width of the apical base of the upper jaw is 44%, lower 40% of the sum of the measured distal dimensions of the 12 permanent teeth of each jaw. Normally, the length of the apical base of the upper jaw is 39%, lower 43% of the sum of the measured distal dimensions of the 12 permanent teeth. One of the most valuable diagnostic tools in orthodontics are radiographs. Radiologic investigation is necessary for diagnosis, clarification, defining the plan and prognosis of treatment. It is important, depending on the aim, to choose the most effective method of radiologic investigation correctly. A wide range of X-ray techniques is used for diagnosis of the maxillofacial area. Radiography is a technique involved in producing various radiographic images. A radiograph is only prescribed after a full clinical examination to ensure that information cannot be gained a less invasive method. Intraoral periapical radiographs. Intraoral periapical radiographs are used to view the teeth and their supporting structures, to confirm presence or absence of teeth, to establish presence or absence of supernumerary teeth, to determine size and shape of unerupted teeth, to assess axial inclination of roots, to study alveolar bone and periodontal tissue, finding out destructive changes, cysts, new formation, congenital and acquired defects, and also the clarification of teeth germs position anomalies, the degree of their crowns and roots formation, teeth retention, their form anomalies, correlation of deciduous teeth roots and permanent teeth crowns. Upper occlusal radiograph. Occlusal radiographs are carried out with the help of dental X-ray machines by direct close focus method. This gives a view of the maxillary incisor region and is used to assess the root form of incisor, detect the presence of supernumerary teeth, to locate ectopic canine teeth. Upper occlusal radiograph is useful for studying of the median palatine suture structure, the degree of its ossification. Orthopantomogram. The orthopantomogram, also known as a dental panoramic tomogram, is a critical diagnostic tool as it shows upper and lower arches with surrounding structures. This type of extraoral radiograph is commonly taken prior to treatment to aid in accurate diagnosis and that at the end of treatment to ensure that the crown and root position are ideal. This radiograph must be examined a systematic approach working from one side to the other, assessing the position and size of the permanent and primary teeth, tooth development or dental age, missing and extra teeth or hypodontia or hyperdontia, alveolar bone density and height, root inclinations, impacted or ectopic teeth, and presence of pathology. Tomography is a general term used for technique that provides an image of a layer of tissue. The versatility of this technique makes tomography highly desirable for accurate imaging of maxillofacial structures, including the TMG, and for cross-sectional imaging of the maxilla and mandible. Modern complex motion tomography units can be optimized to image and selected region of the facial region. Conventional computed tomography imaging involves the use of the rotating X-ray equipment combined with a digital computer to obtain images of the body. Combined computed tomography is a faster, more compact version of traditional ST with a low dose of radiation. The three-dimensional views produced may be useful in certain orthodontic cases, accurate location of impacted teeth, and a more accurate assessment of any associated pathology, particularly resorption of teeth. Assessment of alveolar bone coverage, cleft palate, assessment of alveolar bone height and volume, TMG or AV analysis, planning of some complex combined orthodontics and orthodognatic surgery case. Cephalometrics. Cephalometry is the analysis and interpretation of standardized radiographs of the facial bones. Cephalometry allows establishing the level of the malocclusion, cranial, gnathic, dental, and mixed, in order to select the optimal method of treatment. Cephalometry are used in orthodontics diagnosis and treatment planning. Cephalometric analysis may provide useful information for assessing sagittal, horizontal, vertical, skeletal relationship, incisors position, inclination, soft tissue profile. Cephalometry helps in evaluation of treatment results, helps in predicting growth-related changes. Several types of cephalometry exist. First, lateral cephalogram, X-ray beam perpendicular to the patient's sagittal plane. Second, frontal cephalogram, X-ray beam perpendicular to the patient's frontal plane. Cephalograms are most often performed with a special equipment, collimated X-ray source and cephalostat head positioned. Evaluation of cephalometric radiograph carried out with help of light viewing box by applying anthropometric points on it and further studying the linear and angular parameters. More than 100 anthropometric points and 200 methods of cephalometric analysis have been described in the literature. Commonly used anthropometric points are sella, the midpoint of the sella turcica; nasion, the most anterior point midway between the frontal and nasal bones suture; basin, the most anterior point on the foramen magnum; a point, the point of deepest concavity on the anterior profile of the maxilla; ANS, anterior nasal spine. It is a tip of the sharp bony process of the maxilla in the midline. PNS, posterior nasal spine, the most posterior point in the bony hard palate in the sagittal plane. B point, the point of deepest concavity of the anterior surface of the mandibular symphysis. Gnation, the most anterior inferior point of the symphysis of the chin. Gonion, the most posterior inferior point of the angle of the mandibula. Orbitale, the most inferior anterior point on the margin of the orbit. Pogonion, the most anterior point on the mandibular symphysis. Porion, the uppermost, outermost point on the bony external auditory meatus. Commonly used reference lines and planes. NS, the plane of anterior cranial base. SPP, the spinal plane, palatal plane. A line linking nasal spine of the maxilla and the posterior nasal spine of the palatal bone. MP, the mandibular plane, a line connecting gonion and gnation. Frankfurt plane, the line joining the porion and orbitally. Functional occlusal plane, a line drawn between the cusp tips of the permanent molars and premolars. The following angles are commonly used in cephalometric analysis. SNA angle. The angle is normally 82 degrees and characterizes the position of the anterior point of the apical base of the maxilla in relation to the anterior part of the skull base. An increase in the angle is upper prognatism, and a decrease in the angle is upper retrognatism. SNB. The angle is normally 77 degrees and characterizes the position of the anterior point of the apical base of the mandibula in relation to the anterior part of the skull base. An increase in the angle is low prognatism, and a decrease in the angle is low retrognatism. NSBA is the angle characterizing the relationship between the anterior and posterior points of the skull base. NSL is the angle characterizing the position of the upper jaw base plane in relation to the anterior skull base. NSL is the angle characterizing the position of the mandibular base plane in relation to the anterior aspect of the skull base. MLNL, intermaxillary angle, is the angle characterizing the mutual location of the bases of the upper and lower jaws. ANB angle denotes the relative position of maxilla and mandibula to each other. Mean value is 2 degrees. An increase in this angle indicates class 2 skeletal tendency, while an angle that is less than normal or a negative angle is suggestive of a skeletal class 3 relationship. Width analysis. This analysis compares the relationship of the maxilla and mandibula with the occlusal plane. Perpendicular lines from both point A and point B are drawn to the functional occlusal plane to give points AO and BO. The distance between AO and BO is then measured. The average values are 1 mm for males and 0 mm for females. That's all. Thanks you for your attention. Goodbye and good luck.